Hello students, I am Dr. Shamla from Department of Orthodontics. Today you will be going to learn how to manage Class 1 and Class 2 malocclusions. So in today's lecture, you should be able to, by the end of it, identify the etiology of Class 1 and Class 2 malocclusions and formulate a treatment plan for them. So all of you know by now what is a class 1 malocclusion. So I give it a minute for you to re-examine what you already know, right? Okay, so moving on. Class 1 malocclusion, as you all know, is when a mesiobuccal cusp of your upper permanent molar lies on the mesiobuccal groove of your lower first permanent molar. Yes, so this is called as an ideal occlusion, whereas a malocclusion means when that is happening in the molar, but still you have some malocclusions in the arch, right? That is called as class 1 malocclusion. So the types of class 1 malocclusion is few of the most common are bimaxillary protrusion or proclination, crowding of your maxillary and mandibular teeth, and spacing, rotations, open bite, deep bite, cross bite, etc. So what do you understand when I say bimaxillary protrusion? That means bimaxillary, the jaws are protruded, right? Bimax, both jaws, right? So skeletally, how will a patient looks like? Okay, so as you see in the picture, they have prognathic jaws. That means definitely they have an increased A&B angle, convex profile, and everted lips. Dentally, what do you see in these kind of patients? So dentally, a bimax proclination you can see, right? So you see definitely there is a proclination of your upper and lower teeth. Okay, there is spacing here, okay, that you might see, but the molar and canine might be normal. That is, molar is still in class 1, okay, but you have some malocclusions going on in the arch, right? Also, you will see that a class 1 molar, okay, has a crowding, a spacing, rotations, etc., or a transverse malocclusion. Okay, so in this picture, you will see a classic bimaxillary protrusion case, okay, with some crowding over here, spacing, okay. Now, when I say treatment, how do you treat these kind of patients, right? So the key is to maintain the class 1 molar relation. Now, when you all have taken case histories, okay, not only for, you know, specific case, okay, 95% of the cases that you treat, you should aim, your treatment objective should be to achieve a class 1 molar relation, okay, after your orthodontic treatment, if there is not, right? But for example, a patient is coming to you with a class 2 malocclusion, right? But you have to just correct the midline diastema. Patient is not bothered about the class 2. He wants you only to correct the midline diastema. Your objective should be to address the chief complaint first, right? But you should give him the option of correcting the class 2, right? But the key there would be to address the chief complaint. Whereas in normal cases, okay, the patient is just come to you for orthodontic treatment and you see that the molar is not in a class 1, okay, you have to achieve the class 1 molar relation. And when the patient is coming to you with a class 1 and few malocclusions, okay, the objective should be to maintain a molar class 1 relation, right? So there are two things that you need to focus here: to achieve a class 1 molar and to maintain the class 1 molar, right? Both of them are very, very important here. So of course a diagnosis, okay, this follows for all the malocclusions, right? The key to a good diagnosis is to take a case history, okay, a detailed case history, clinically examining the patient, okay, taking the study models, because of course the patient might not be there with you all the time, right? So when you have to formulate a treatment plan, you must have a good study model with you, or at least a pre-treatment photographs with you, right? And under radiography, the most common that we take for orthodontic treatment is your OPG and your lateral ceph, right? So in few cases, of course, you might need the IOPA as well, but most commonly OPG and lateral ceph will do the job. Now moving on to specific malocclusions that come under class 1, right? So when you have a malocclusion, right, a class 1 malocclusion with spacing, what do you do? Yes, so as you see in this picture, you have a spacing, right? Okay, so generally how do you treat spacing? Okay, so let's see that. When you see there is a spacing or any malocclusion, identify the etiology first. Okay, are there habits involved? Is it genetic? Okay, did the mother take any drug during pregnancy? Okay, so what is the etiology? The patient, if you don't treat the etiology, okay, then it is going to rebound, okay, or relapse back, right? So the key is to understand the etiology, okay. So if there is a midline diastema, take an OPG, okay, or an IOPA to check if the frenum is the problem, right? Assess the condition here, whether the frenum is the problem, okay, or there is a supernumerary teeth inside, right? Yes, so you have to assess, okay, and see why there is the problem here, okay. So when you see a generalized spacing, okay, eliminate the etiology first, okay. When it is a microdontia, okay, what is a microdontia? Yes, you are right. So teeth which are smaller in size than your normal set of teeth, okay. Yes, so if a teeth is microdontic, right, so you try to see which is the teeth first of all, right, and see if you can build the teeth, right. So with a composite buildup, either you can build the teeth or you can close it with a removable retainer, okay, and close all the other spaces, and whether you want to give a prosthesis, okay, or an implant to fix that space, it all depends upon what is the problem and which teeth is the problem, okay. Now for example here, suppose that the teeth is, the lateral is microdontic over here, right. So this is microdontic, okay. So and all the other teeth are having a generalized spacing. So when this is microdontic, okay, you can either close all the spaces, right, and then you can build it up endodontically. Yes, so that will can be an option, right? Okay. Moving on, spacing with proclination. Okay, so when you have a space, okay, and the teeth is proclined, right? Okay, we are talking about definitely, minor proclination, not a severe proclination. Okay, that cannot be treated with removable appliance. It has to go for fixed. So when you have a minor over jet, okay, you can definitely correct it, as you all know, by your removable Hollis appliance, okay. The labial bow, when you activate the labial bow, the proclination reduces, correct. Okay. Now when you see a crowding, it is very very important, okay, to not jump the gun and decide that you want to extract, okay. Yes, you must understand if the crowding is there, how much crowding is there, right? Suppose here you have, say, about, you must understand with your model analysis here, the model analysis plays a very very important role, right? So you must understand the tooth size discrepancy, okay, or tooth material to tooth size discrepancy, okay. Analyze the space that you have first, okay, then you see how much of space you need, okay, to correct that particular crowded tooth, right? For example, let's focus on this picture over here, okay. So suppose that this is the case, right? So the canine is little bit of crowded over here, Yes, so if only one tooth is like this, of course you cannot think first of removing the all four, extracting everything. Okay, if everything is normal and only one tooth is crowded like this, okay, there are a lot of things that you can think of in your treatment options, right? It all depends upon how much of space is available and how much do you need. Okay, so suppose you have, what is the mesodistal width of your canine? Yes. Okay, so it is about say 8 mm, right? So if that is the case here, okay, 6 to 8 mm, right? You see there, okay, so if that is the case and you have only 3 mm of space left, so you need only an additional 3 mm of space, right? For that, do you want to extract all the premolars? You must think like that, okay? Now, as I said, if crowding is up to 4 mm, usually can be solved non-extraction. That means you can do proximal stripping, okay, or you can slightly procline the tooth if there is no overjet, okay. If crowding is between 5 to 9 mm, then of course you will need to extract, right? Extractions are important there, right? But also you must see the extraoral features of the patient, right? And see if it can be done still by non-extraction, okay? Methods such as your expansion, proximal stripping, molar distalization, right? So you must analyze the arch first. If the crowding is more than 9 mm, okay, definitely, most of the cases extractions are required. Okay. Now, which teeth to extract depends upon canine relationship. Okay. So it depends whether you want to extract the first premolar, you want to extract the second premolar. It depends all about. Okay. It varies case to case, right? It is case to case basis. Okay. But mostly the canine tells us, gives a clue, right? Which teeth to extract. Now, this is a funny picture here. If everybody is doing the same way, extracting all teeth, I will also do it. So that should not be your mentality, right? So, of course, the model analysis and other space calculating guidelines, okay, are important for your diagnosis, but you should not blindly follow them, right? Always analyze the full case. That means see your case history, see the intraoral, extraoral features of the patients, right? See your, OPG lateral ceph, okay, and model analysis, and then discuss with the patient, okay, the various treatment options and come to a conclusion together. Okay, that's how you improve your patient relationship. Now, let's see how to write or how to understand rotations. Yes, okay. So, what do you think? How can you write this tooth? Okay, how do you write the rotation for this tooth? Okay, this, so follow the midline here, right? This is the midline, right? If I say the tooth is rotated, that means it is either the mesial side, so mesiolabially, okay, or mesiobuccal, okay, or distolingual. So this is the mesial side of the tooth, okay, and it is out, so it can be mesiobuccal or it can be distolingual. Okay, so that's how you can write. Okay, so first and foremost, you must understand when you see a malocclusion, try to first solve it maximum with your removable appliance, right? Yes, so it is easy also and economic also. Of course, in most of the cases, you require, okay, to put braces. Okay, so simple rotations can be corrected with double cantilever spring, right? Multiple rotations, definitely you require a fixed orthodontics for the correction, right? And this is an MCQ question and very, very important. Okay, so rotations are one of the most common malocclusions which require permanent retention. Of course, others also do, but definitely it is advised to overcorrect a rotation because it is going to relapse for sure. Okay, now coming to deep bite. So all of you know by now a deep bite is an increased overbite. Yes, so the bite, as you can see in the picture, we have an increased overlap of your upper incisors to your lower incisors. Okay, it is called as your bite. Now a deep bite can be broadly classified as skeletal or dental. Yes, so correction depends on age of the patient, growth pattern, right, anterior gingiva and tooth display, okay, periodontal health and root health of your anterior teeth. Okay, let's see that. Okay, when you have a deep bite like this, okay, yes, how do you think you can correct it? Now take a moment, try to understand the situation over here and come up with what you all know already, right? I'm sure most of you know how to do it. So either you can intrude your anteriors or extrude your posteriors. Yes? Okay. So if you intrude, imagine this, if you are doing an intrusion of your anteriors, then these anteriors are going to go up, right? Yes or no? That's how you can correct a deep bite. Okay. Now, a most common appliance that we give to correct a deep bite is your anterior bite plane. That means you have a removable appliance. Okay, they have an acrylic base plate, and here there is an extra layer of acrylic. Okay, over here like a bite plane, right? So these bite planes are required for overbite reduction and are made behind the incisors and your canines. Okay, the bite plane should be flat. Okay, it should not be inclined. This is to avoid proclining forces on the mandibular anterior teeth. The thickness should be sufficient enough for you to open the bite in the premolar region. Okay, that's how you decide. You don't just keep on bulking it and in later you will achieve with a severe open bite, right? So you must keep that in account. As the overbite reduces, additional acrylic can be added to raise the platform and continue the overbite reduction. Now, how does an anterior bite plane work? An anterior bite plane prevents the lower teeth to contact the cingulum of your upper teeth or the gingiva, right? So this causes an posterior open bite. So naturally the body tends that, okay, there is an open bite, okay, there is a space, definitely there can be a supra eruption. A simple case would be, suppose you are extracting a tooth, okay, suppose you are extracting a lower first molar. When you extract and leave it for a very long time, don't you think that the upper molar will come and occupy that space? Yes, that means it will supra erupt. That same philosophy follows here. Okay, now I'm going to play you a short video so that you can all understand how this works, right? Okay, so you give a bite plane over there. Okay, so you see the lower teeth hitting the bite plane, right? So there is an opening of the bite there and a supra eruption happening there. Okay, definitely the bite has improved. Okay, moving on. Remember, I was talking to you about bimaxillary protrusion. Okay, so how to treat them? When you see a bimax case, okay, definitely space is needed to push the teeth back. Yes, so either you can do it by your fixed appliance or you can do a surgical correction, right? So fixed appliance, basically if you are putting, definitely it requires extraction of your premolars, right? In surgery, it depends upon the jaw. Which jaw is at fault, right? So if maxilla only, you do a leaf-foot 1 osteotomy for maxillary intrusion, okay? Or if mandible is at fault, it has to be pushed back, then bilateral sagittal split osteotomy, which is your BSSO. Okay, so now moving on to your class 2 malocclusions. All of you know what is the class 2 malocclusion, so I'll be not going into detail about the definition and all. So when I say etiology, okay, what is the reason that you have a class 2? Okay, mostly it is genetic, okay, and also congenitally, okay, congenital problems, right? So sleeping habits, trauma, radiation, infections, okay, forceps delivery, all these things can lead to class 2. Okay, so most commonly if you see a class 2, okay, most of them will be having, okay, congenitally missing teeth, most commonly your lateral incisors. You will see peg laterals, okay. Then premature extraction in the upper buccal segment can also lead to class 2 malocclusions. Over retention of your lower deciduous teeth, okay, can also lead to malocclusions. Okay. Now a class 2 division 1, okay, all of you know that the class 2 malocclusion has two subdivisions, class 2 division 1 and class 2 division 2, and also subdivision malocclusion, right? So a class 2 division 1, the classic feature would be, okay, proclination, as you all know, okay. So intraorally the patient exhibits a class 2 molar relation or an end-on relation. The classical feature of class 2 div 1 is the presence of procline maxillary anteriors and increased overjet. The patient might have a convex profile, deep bite and excessive curve of spee. Due to increased overjet, lower incisors do not contact the uppers and therefore they are free to erupt. Patient might be having a short hypotonic upper lip, lip trap, lack of anterior lip seal, abnormal buccinator activity, and procline anteriors, lower anteriors for compensation. Now these are the pictures. You see how a classic class 2 division 1 looks like, right? So you might have an end-on or a class 2 molar, but definitely you will see a proclination here, right? So you might also see a constricted arch. Yes, cross by. This is very important. Yes, this is your MCQ question. Lip trap is seen in which kind of malocclusion, right? So more specific, even though they might write their class 2, you must choose the class 2 division 1 malocclusion, right? If that is an option. All of you must understand, okay, when there is a skeletal problem, you must find out first which jaw is at fault. Now imagine you are seeing a patient with a class 3, right? So I am assuming you all might just sit and imagine how a class 3 looks like, right? So a class 3, if you most 95% of the normal population would think that a class 3 is because the lower jaw is in the front. Well, that might not be the case. The upper jaw might be back and lower jaw might be in a normal position. Yes or no? Yes, so you must understand first which jaw is at fault and subsequently decide the treatment plan, right? Whether the problem is because of maxillary protrusion, okay, in this case, however, it might be due to maxillary protrusion, okay, or right, or you can have a mandibular retrusion, or you can have a combination. Yes, okay, so many things are there. When you have skeletal features, okay, you must see which jaw is at fault, right? So the treatment planning definitely depends on, okay, reduction of the overjet, right, overbite, correction of crowding, expansion of constricted arch, correction of posterior cross bites, if there is an unstable molar relation, example end-on, and normalizing the muscles, right? So treatment, I have given a flow chart over here for your better understanding, and you can write it easily in your exam papers, right? So a class 2 malocclusion, when you see, right, the treatment plan can be divided into growing patient and non-growing patient. Yes, when you see a growing patient, first and foremost, or a non-growing as well, whether the problem is skeletal or dental. The class 2 is because of skeletal jaws problem or a dental teeth problem. Okay, so that will decide on your treatment plan. Now if a patient is growing, okay, but has a skeletal, because of a skeletal problem, has a class 2, now depends in that skeletal whether it's maxillary prognathism. If it is a maxillary prognathism, then you give a headgear to restrict the growth, maxillary growth, right, and allow the mandible to grow on its own. or to maintain. A maxillary prognathism and mandibular retrognathism, you have to give a headgear with myofunctional appliance, right? Because the mandible is retrognatic, you might want to pull the mandible forward, right? And headgear to restrict the maxilla. Mandibular retrognathism, you'll definitely need a myofunctional appliance. Now, in both the cases, when the problem is dental, definitely ortho treatment or fixed appliance is the go-to answer, right? Now, coming to non-growing patient, when the patient is non-growing and has a skeletal problem, the first thing you might that comes to your mind is surgery. Well, that is true. Now, that depends upon whether the case is mild to moderate class 2 or it is a severe class 2. When it is mild to moderate class 2, you can do still the treatment with camouflage. Okay, that is by extracting some teeth. What is camouflage? What do you understand by the term camouflage? Means you are masking the problem, but the problem is not gone. Yes, still you can, you are not fixing the problem. Okay, just masking the problem. Okay, that is what is camouflage, right? So if there is a mild to moderate, you go for camouflage. If it's a severe class 2, it depends on whether the problem is in the maxilla, that is maxillary prognathism, then you do a Leafort 1 osteotomy with maxillary setback. If it is a mandibular retrognathism, you do BSSO, okay, that is bilateral sagittal split osteotomy, right, with mandibular advancement. Okay, so I want you all to go and read through this and see if you can understand, right? So I hope myofunctional appliance and the orthopedic appliance chapters are done, so you know how these appliances look like, how they work. Okay, so I'm not going into much detail about it. Okay, right. So in this slide, you can see that if the patient is at the end of the growth period, right, you have to give something like a fixed functional appliance, right? Example, your Jasper jumper or your Herbst appliance, right? So this will be taken separately for you. Like I was telling to you, what is a camouflage? Okay, so this is done by extracting certain teeth, right? Yes. And such repositioning is likely to have favorable effects on facial aesthetics of the patient. Okay, so patient is looking still good, okay, without the surgery. Okay. Okay, so in this I would like to show you. Okay, so this is bilateral sagittal split osteotomy I was talking to you about, right? A maxillary setback. Okay, so moving on to class 2 division 2 malocclusion, right? So what is a class 2 division 2? All of you know how a class 2 division 2 looks like? Yes? So the upper central incisors show a lingual inclination and the lateral overlaps the central. Okay. So intraorally, you will see a class 2 molar relation, class 2 canine relation. Okay, the arch might be square. Upper central incisors are retroclined, lateral incisors are proclined. So any 5 or 6, if you write from the intraoral features, more than enough. Okay. So what is the objective? First and foremost, to relieve the gingival trauma if there, correction of incisor relation, and relief of crowding and minor irregularities. Okay. Now when there is a simple case, alignment of incisors can be achieved by removable appliance such as Z-spring, right? But mostly these cases might require an orthodontic, that is fixed orthodontic treatment, right? Now under that you might require to remove teeth, that is mostly if there is a case like this. Okay, so class 2 division 1, either upper 4, lower 5 extractions or distalization. Okay, so with this we have come to the end of the lecture. Thank you all of you. If there are any doubts, send me a personal or private message in e-portal, and I hope you all are safe and practicing a good hygiene. Stay safe. Thank you.